Welcome to part 5 of respiratory, and this section we're going to talk about pneumonia. Pneumonia is inflammation of the lung parenchyma, which is the gas exchanging portion of the lungs. Pneumonia can be caused by bacteria, mycobacteria, fungi, and viruses. And there are 4 main types of pneumonia. The first is community-acquired pneumonia, or CAP. CAP occurs out in the community, or it's going to develop within the first 48 hours of hospitalization. So if they get pneumonia within 24 hours of being hospitalized, we know they didn't get it from us, they got it from the community. Older adults are more susceptible to CAP and have higher rates of hospitalization due to CAP. Streptococcus pneumoniae is the most common cause of CAP among adults, and it's a bacteria that lives naturally in the upper respiratory tract, and it can cause other issues like ear infections and sinus infections. Before COVID, we didn't see many viruses causing CAP in older adults, but COVID really does cause the majority of virus-related CAP that we're seeing now. People who are immunocompromised are more at risk to develop pneumonia from fungi and even yeast, but both of these are incredibly rare and incredibly difficult to treat. The next type of pneumonia we have is healthcare-associated pneumonia. Now, this is not hospital-acquired. This is someone who's been in contact with healthcare, like nursing homes, infusion centers, dialysis centers, or even urgent care, and then they get pneumonia. And this pneumonia is typically multi-drug resistance. This type of pneumonia can be very hard to treat, and usually we're using different antibiotics to treat this that are going to be different antibiotics than what we use to treat CAP. Now, hospital-acquired pneumonia, or HAP, is a subtype of healthcare-associated pneumonia, but this type of pneumonia occurs 48 hours or later after hospitalization. And because there are so many sources of infection in a hospital, people who are hospitalized are typically sick and their immune system isn't properly functioning. So all of those sources of infection just kind of attack them and give them really bad pneumonia, and there's a really high mortality rate related to HAP. It is not uncommon for these patients to have multiple types of pneumonia happening at the same time, causing the HAP. The last type of pneumonia subtype we have is actually a type of hospital-acquired pneumonia, and that's VAP, or ventilator-associated pneumonia. This type of pneumonia is in people who are on a ventilator for at least 48 hours, and VAP is something you will talk about in depth in Block 4. Now, what's happening with pneumonia? Normally, the upper airway prevents potentially infectious particles from reaching that sterile lower respiratory tract. We've got the nose, we've got the pharynx, we've got all the little nose hairs that usually collect everything. But in pneumonia, the upper airway is going to fail to prevent this from happening. If our patient is immunocompromised, their own normal flora might cause the pneumonia because their immune system's not working correctly to keep their own normal flora from taking over. Usually these immunocompromised patients or people who get bad pneumonia have some sort of underlying disease like diabetes mellitus, maybe COVID or bronchitis that's lowering their immune system's ability to function, and then they get pneumonia. Sometimes pneumonia can occur from a blood-borne organism that gets trapped in the pulmonary capillary bed and grows out of control. Remember, those alveoli are covered in capillaries because that's where gas exchange happens, so you could get bacteria in the blood get into the lungs. Pneumonia then causes an inflammatory response in the alveoli, which is going to cause the alveoli to produce exudate or fluid that is going to trigger white blood cells to travel to the alveoli, and now our alveoli are filled with white blood cells and fluid, that exudate. It's going to take over all that alveolar space. This causes the alveoli to not be able to diffuse oxygen and CO2, making this a diffusion disorder. However, that exudate can overwhelm the alveoli and start traveling to the larger airways, which is going to reduce airflow. So pneumonia is also a ventilation disorder. Because of all of this, the gas exchange portion of the lungs can't get enough oxygen to diffuse into the blood. So that blood that's entering the lungs and leaving the lungs, it's leaving the lungs without the oxygen that it was supposed to have gotten, and it's got more CO2 than it's supposed to because it couldn't diffuse the CO2 back into the lungs either. So now our oxygenated blood isn't oxygenated, and this is going to lead to a condition called hypoxemia. Hypoxemia is low oxygen levels in the blood. We also have a disorder called hypoxia, which is lack of oxygen to the tissues. These are very similar terms with very different meanings, but you hear them used interchangeably all the time. And the reason why they're used interchangeably is because if you have hypoxemia, you will have hypoxia. So if I have someone who I say has a hypoxia, it's already kind of granted that they have hypoxemia. There are many risk factors for pneumonia. Of course, hospitalization is a major risk factor, but so are many common medical disorders we see, like heart failure, diabetes, alcoholism, COPD, smoking, influenza, COVID, and cystic fibrosis. I also want to add operations. Post-operative patients who develop atelectasis are at a very high risk of having that atelectasis turn into pneumonia. If the person is laying supine for too long, they can develop atelectasis, which will turn into pneumonia. Someone who can't cough effectively is going to be at risk for pneumonia. And honestly, any single person who develops a risk for atelectasis is at a risk for pneumonia. Unfortunately, pneumonia is a deadly disease. It has a lot of complications from the pneumonia itself, especially in high-risk patients, but also the complications from being hospitalized. The pneumonia itself can cause sepsis, which is a deadly blood infection, and you talk more about that in later blocks. And it can cause respiratory failure, which could require intubation and mechanical ventilation to treat it. It can also cause death. And in addition to these people can get malnutrition and they can get pressure injuries. Elderly adults are at higher risk of developing pneumonia, and they have a higher mortality rate and are much more likely to be hospitalized due to their pneumonia. Elderly patients also do not always get the classic symptoms of pneumonia due to some of the medications they're taking for other diseases, so a lot of times they get diagnosed later than they should have. They also get much sicker with pneumonia, and many of them do end up in the ICU. We really need to encourage our elderly patients to get their annual influenza vaccine and the pneumococcal vaccine to help prevent pneumonia. The pneumococcal vaccine is going to help prevent CAP, but it's not going to do anything to prevent healthcare associated or hospital associated pneumonia, but it can't hurt. I mean, it can't hurt. They need it. Elderly patients who have both vaccines, so pneumococcal and influenza, have a much lower rate of pneumonia during those high peak seasons. The symptoms of pneumonia can vary depending on the type of pneumonia, what organism is causing the pneumonia, and what other diseases the person has. People who have pneumococcal-related pneumonia usually have sudden onset of chills with a rapidly rising fever, and we're talking like 101 to 105 Fahrenheit. They can also develop pleuritic chest pain, meaning every time they breathe, their chest hurts, and that pleuritic chest pain is made worse by coughing and deep breathing. The person usually gets severely ill and develops tachypnea and respiratory distress, and people with pneumococcal pneumonia can develop a rust-colored sputum, and a lot of times if we see rust-colored sputum, we're like, oh, they've got CAP. In viral pneumonia, the pulse rate doesn't get as high as it should or as high as we expect for how high their fever is getting. So it's weird. We expect someone with a fever to be tachycardic, but with viral pneumonia, they're not tachycardic. But they do get the same cough and chills and fever and malaise as bacterial pneumonia. Other common pneumonia symptoms include a poor appetite, diaphoresis, fatigue, decreased oxygen saturations, orthopnea, which is difficulty breathing while laying down. They'll get purulent sputum, crackles in their lungs, and they may develop a headache. We also have to note that in people with COPD, which is a chronic lung condition where they have inflammation and they cough a lot, their only symptom might be that now they have purulent sputum when they didn't have sputum before. When we assess a person for pneumonia, it's going to involve a detailed history and physical examination. We want to check their vital signs, inspect and auscultate their lungs and their lung sounds, look at their breathing for tachypnea, shortness of breath, and cough. We want to assess the cough's frequency and its severity, and we want to look at their sputum for color and consistency and amount, and we also want to send their sputum for culture to see what organism is growing. We want to assess for fatigue and dehydration and changes in mental status. I said earlier that changes in mentation are one of the first signs that we're going to see if someone has a low oxygen level. We can also send blood to be cultured to see if they have an infection in their blood, and we want to take an x-ray to see if we can see the pneumonia on x-ray. Now, nurses do not interpret x-rays. We can see them in the system, but they're not anything that we are trained to do or what we do. But I wanted to give you some examples of x-rays. So on this slide, we have an example of a normal chest x-ray. The areas that are black or less bright gray are areas where there's air. We should have dark areas like this all over the airfields. The spine and the ribs are clearly defined because bone is hard and dense and x-rays don't go through them as easy, so that's why they're darker gray to almost bright white. The heart is more gray because it's full of fluid and x-rays don't go through fluid as easily. And at the bottom of the x-ray we have those abdominal organs, and those are also full of fluid, so we don't get x-rays going through those either. So take a peek at this x-ray. We're going to compare it to some pneumonia x-rays on the next slide. So on this slide, we have some pneumonia x-rays. Remember, pneumonia is exudate. It's fluid in the alveoli, and x-rays don't go through fluid as well. So any areas where we have pneumonia are going to appear more gray and not black like we expect with the airflow. The picture on the left is of my son. He got, in quotes, the flu a few months before COVID was really known about or a thing. If you look at his x-ray, he's got some fluffy fluid all around his heart, and up in the left upper lobe, it's completely full of fluid. If you look at that upper left, he doesn't have any black or any darkness. That's not normal. That's not common with influenza, and it's definitely not common with kids. So it makes me wonder what he really had. The middle x-ray is an x-ray of COVID pneumonia. If you look at the bases of those lungs, they're full of pneumonia. They're really fluffy, full of fluid. Actually, it's even fluffy and full of fluid to a good halfway up those lungs, with only the apices of the lungs getting any really good airflow, because that's the only area we're seeing black. The x-ray on the right is showing really bad pneumonia in that left lung. The left lung is almost completely white out, meaning there's very little airflow to that lung because it's so full of pneumonia fluid. Any provider who sees these x-rays in combination with the patient's symptoms is going to diagnose these people with pneumonia, and it's going to start them on treatments right away. The main treatment for pneumonia is antibiotics, assuming it's bacterial pneumonia. Viral and fungal and yeast pneumonias will not respond to antibiotics, and if we did give them antibiotics, it's only going to create superbacteria in the body. It's going to kill off their normal flora, and it's going to put them at risk of getting C. diff. Preferably, we'd like to send a sputum culture to the lab before we started antibiotics, so we get a good idea of what organism is causing the pneumonia, so we can make sure they get the correct antibiotics. But cultures take 48 to 72 hours to grow, and we need to start this person on antibiotics. So we normally will start them on antibiotics to start killing off whatever bacteria we think they have. And then when the sputum culture comes back, we may need to change them to a different antibiotic that works better for that bacteria. We start them on what we call broad spectrum antibiotics, or antibiotics that kill a lot of different types of bacteria. We use that one first until we get that culture back, and if we need to change them, we will, and if not, we'll leave them on the broad spectrum. If the person's hospitalized, we're normally going to start them on IV antibiotics until they're feeling better and well enough to take orals. Because if they're in the hospital with pneumonia, they're probably pretty sick. In the community setting, we normally just give oral antibiotics for anyone with community-acquired pneumonia. Supportive treatments are going to include fluids, either orally if they can, or IV. We'll use oxygen for hypoxemia as needed, antipyretics for fever, antitussives to help with the cough, decongestant to help open the airways, and antihistamines to help with some other symptoms. We can also give bronchodilators to help open the airways, as well as give prednisone to help inflammation in the lungs. However, we need to watch prednisone because it raises blood glucose levels, and if our patient is diabetic, hyperglycemia has many complications for them that we want to avoid. Also, bacteria love sugar, so hyperglycemia could potentially make the pneumonia harder to treat in diabetics. The goals of our nursing care are to improve airway patency with coughing and deep breathing exercises, like using the incentive spirometer and increasing activity like up to the chair ambulation. We want to maintain proper fluid volume, so we encourage fluids and even give IV fluids. We want to maintain or improve nutrition, so we encourage eating, and we may have to do enteral feedings if they're too ill to actually eat. We need to educate the patient on the treatment plan and preventative measures, not only so they don't get pneumonia again, but to help prevent complications like pressure injuries and malnutrition. And this is the end of part 5.